here, where her research,
Recording in progress,
of that is focusing on the neonatal brain, whether this is, pathways to injury, mechanisms of injury, and treatment of injury in a trial-like fashion. Today we have a special setting, of course, because she's original, from my understanding, from New Zealand, where, of course, you must have worked with Alistair as well. I know Alistair only from this.
Yeah, and I'll touch on that. On that.
Perfect. Because Alistair spoke here, I think it's about 3 years ago, about seizures in the Alistair way. His depth and interest into understanding, particularly the mechanism, was amazing to learn from. So today, over to you, Terrie.
Well, thank you so much, and I am going to acknowledge right up front. And I'll try and hold it together as I do this, because it is really heartfelt. To be asked to acknowledge and to remember our colleague, Alistair. I was actually in South Africa at an MRI meeting when I received the very sad news of his untimely passing. And I'd had the privilege of putting together some slides to recognise Alistair based on my knowledge and experience with him over decades. And did that for the time that we got to honour him as a fellow in the International Newborn Brain Society, which has been a reserved honour for a very few number of people in our field. And Alistair was one of the very early recipients, recognising his outstanding and amazing contributions. He's a scientist, and a physiologist, a physician, an endocrinologist, an innovator, and a son, husband, and father, and an exceptional colleague. He was born in New Zealand, and he came into an extraordinary family. I also had the privilege of working with and knowing personally his mother, Tanya, who was quite extraordinary. And his father was a geologist who worked in Antarctica initially during the time even of the Hillary expeditions. His mother was really a leader, particularly as a young woman for me, coming through in a field that was very dominated by men. In fact, in the South Island, there were no women paediatricians when I trained. She was an absolute, leader in newborn medicine. She introduced Alistair to the thought that you could work around the world, travelling between Australia, the United States, and Canada from a very young age. And he was the eldest of four, with two younger brothers and a younger sister. And he got the privilege, when his mother retrained in the North American system, of having some of that experience. He did medical training in New Zealand, his paediatric residency in paediatric endocrinology fellowship. Obviously, he was influenced by people like Peter Gluckman, who were leading the Liggins Institute, wasn't yet named as the Liggins Institute, but some of this early pioneering work. His research career was in parallel to clinical activity, and it has always led, and what I have always valued greatly about Alistair is the way he has tried to make his research have exceptional translational value. That led then to his hypothermia work. Tanya had always taught Alistair that it was bad to let a baby get cold because of the risks we know of hypoglycemia, coagulopathy, pulmonary hypertension. And he was doing another study relevant to this talk, looking at experimental anti-epileptic drugs and how they could improve brain outcomes. But, he noticed that the rats had a very high mortality, mainly because the rats got cold. And so he thought if he warmed them up, they would do a lot better. And so he warmed them up to see whether the effect would still be protective on the brain. And in fact, he found that it was the opposite, that the rats that were warm did not show any neuroprotection at all. And so then he wondered whether the side effect of being cold was actually really where the gold lay. He went straight into large animal models, really to avoid this difficulty that we had with controlling temperature in small animals. And he was amongst the first to show that mild delayed cooling of the brain after severe ischemic injury would dramatically reduce the injury and improve the recovery of brain function. And as I think we are all aware, it is one of the most outstanding translational models of all time, and that his work elegantly defined how low, how long, and what degree of benefit, and that earlier therapeutic hypothermia, particularly prior to the onset of seizures, was most beneficial. This quickly led to the randomized controlled trials of selective head cooling, showing that it could be safe and improved outcomes. His contributions went above and beyond that. I mean, an enormously prolific publication career, supervising an enormous number of PhDs and masters and fellows, and was recognised both in New Zealand and beyond in terms of his contributions to science and to medicine. But he was so much more. This is where it gets hard. His dedication and hard work, just defined his work ethic. He was so careful in his experimental approach that I admired. He was the ultimate physiologist. He was a penultimate curious scientist, and he was always known in our meetings as the man at the microphone, to get up and ask the most important and clear questions as often as he could. But he always did it because he cared. And there was this kindness and caring in the way that he both inquired but also supported so many people within the field. And that's the Alistair that I will carry forward and always honour in the work that we carry forward in his memory and in the way that his legacy has to be carried forward. He'd recently shown me extraordinary microglial data in his preterm lamb model, trying to align his findings with the work that we do with imaging in the babies. And I was actually emailing with him 48 hours before his untimely passing in May about the timing of fetal heart rate changes with acute ischemia. And that was the level of interaction that you had with Alistair. There was never a question that you couldn't ask, and never an attempt from him at either an answer or then the model to go on and explore where he could discover the answer. And it's just really a challenge to us to continue to take that curiosity, that kindness, and that care about the scientific work we do forward. Of course, we're privileged even to be joined today by members of Alistair and Diana's family. He married an extraordinary physician who accompanied and supported him, and they have 4 beautiful children, with their eldest Eleanor following in the family footsteps in pediatrics. And we hope will inspire her that this legacy in neonatal neurology is also well worth the journey. So today, this is one little tiny piece of the way that I hope we can continue to honour his memory and the scientific enthusiasm driven to improve the outcomes for infants and their families. You are missed, Alistair. So with that, I'll carry on with the things that some of which Alistair taught me and some of which we have grown over time to be able to share with you, what we know and what we still need to know about neonatal seizures. Seizures are very common in the newborn, and we'll talk about why, because this is a unique period, and this is the rodent and the equivalent human, where we've been able to map much more the critical period where the brain is vulnerable to seizures. But as you can see here, there is this period that's shaded out where there's an excess of excitatory presence because of this critical period where the brain wants to undergo activity dependent synaptogenesis and expansion, and also therefore with the absence of excitation have some developmental apoptosis. So it's an overexcitable brain, and it's matched by a lack of the ability to inhibit. So unlike the preterm brain that has quite a lot of inhibitory presence, the term equivalent brain has very little. And compared to adult function, as you can see, where there's actually a much greater balance of excitation and inhibition, it takes nothing more than a strong nor'wester breeze to put the newborn brain into seizures. So seizures are common. 50% of these at least result from ischemic brain injury, but not all seizures. And increased seizure burden is associated with adverse outcome, even after controlling for the extent of brain injury. There are multiple causes, as I've said, of reactive seizures, and hypoxic ischemic injury and infarction and hemorrhage do occupy between 50 and 60%. But increasingly, as we'll talk about towards the end of this talk, we are recognizing the contribution of genetic vulnerability. And also, of course, it's important to screen still for particularly subtle brain malformations. Why do seizures cause brain injury independent of the fact they might be reflecting an ischemic injury? And that's because seizures induce changes in brain energy. And you will see a lot of boxes that are labeled with 15 in front of them. These are taken from the chapters that I had the privilege of co-writing in Volpe's neonatal neurology textbook. And this is one that we summarized from a lot of different authors looking at the data about the utilization and depletion of glucose, both in the cerebral cortex and the thalamus, and the depletion of energy metabolites, particularly ATP and phosphocreatine. And this was shown by a beautiful serendipitous experiment that was done when a baby happened to be in the MRI scanner when the baby had a seizure in one hemisphere. And what is shown here is a spectroscopy between the two hemispheres, the normal hemisphere shown here with the dotted, and the hemisphere undergoing the seizures. And what you can particularly note is for all of the 3 peaks of ATP, that there is quite a diminutive presence of those peaks in the hemisphere that's undergoing seizures. We also know, looking at pathology, that there is quite an impact after recurrent neonatal seizures in any of our experimental models, and many of these are induced with kainate being given to the neonatal mouse. But there's the presence, particularly in the hippocampus, of synaptic reorganization with sprouting mossy fibers, a loss of neurogenesis, and increased susceptibility to later epilepsy because there's this imbalance that's seen between the excitatory and inhibitory neurotransmitters. In the human, there's been quite a number of studies that have looked at duration of seizure versus outcomes. And this is one that was done by Stephen Miller that looked at the duration of seizures here in minutes against the severity of MRI injury. Now, you might say, well, yes, more injury, therefore more seizures. But when they then controlled the MRI scoring and looked just at the log of the seizures against the cognitive outcome, even controlling for injury, you can see that the more seizures you have, the more impaired your cognitive outcome, even after controlling for the amount of injury. Again, you can see here, this is hazard plots of the risk of both developing epilepsy or intellectual disability among newborn infants with or without seizures. And you can see that as the cumulative amount occurs, that the risks go up significantly with those infants who had seizures. We also know that clinical behaviour is not a reliable marker for detecting seizures, which makes it particularly hard for us as clinicians. The types of abnormalities that can be seizures include everything from automatisms like cycling and lip smacking, through to focal and multifocal clonic activity, spasms, myoclonic jerks, a single jerk, or tonic posturing of a limb. Now, there is a difference between the likelihood that those types of abnormalities that may be seizures have underlying EEG correlates. Now, this doesn't mean that there's not something else neurologically going on, because there usually is, particularly in myoclonus. But it's important to know that the clonic movements that don't stop when you hold the limb or the focal tonics are most likely to be associated with abnormal EEG activity that is confirmatory of a seizure. Now, neonatal seizures are often very brief, and this also makes it challenging to diagnose them, particularly with some of the abbreviated forms of monitoring, such as AEG. When you see here, if you look at minutes, the vast majority of seizures are less than a minute long. And so if you're using a compressed type of technology and you're requiring on time, then this can make it very challenging. When do seizures come on? Well, timing can relate to their etiology. So obviously those babies with HIE or arterial stroke tend to come together in the first 48 hours, with HIE being the first 12 to 24, as was beautifully shown in Alistair's data, that it was around 12 hours that you started to see seizures really coming on strongly after secondary energy failure and continuing through that 48 to 72 hour. In contrast, arterial strokes tend to be a little bit later, and arterial strokes tend to occur after the first or around the first 24 hours. HIE in human data is around 14 hours, arterial strokes around 26 hours. And then intracranial hemorrhage, infection, the genetics can come on at any time, but these tend to be a little later. What else do we know? We know that conventional EEG is the gold standard for seizure detection, but that it's not universally available. So in trying to work out how do I, as the person at the bedside, know what to do about whether my baby's having a seizure or not, this type of algorithm was developed by the American Epilepsy Association and by other collaborations to try and understand what's the likelihood that this baby truly is having a seizure. So if there's an event that's suggesting the baby could either be at risk or is having something that looks like a seizure, is EEG available? If it's available, great. Wait and get the gold standard correlate and establish that's definitely a seizure. If it's not available, is AEG available? And if you can use AEG, you may be able to establish that that is probably a seizure. If neither of these are available, is there an experienced observer? And are they seeing mainly these focal clonic or focal tonic, which are more likely to be seizures? Or if there are other types of seizures, or the observer's not convinced, then you may be less likely to diagnose seizure. If you look in the actual literature, it appears, depending on the severity of the underlying encephalopathy that the baby may have, that up to 90% of seizures could be subclinical. Conversely, 2/3 of abnormal movements may not be really seizures. And worse, when you give your phenobarbital, you may dissociate the seizure and the movement because you may cause blockade at the level of the brainstem or the spinal cord. So you may stop the jerking from the abnormal electrical activity, but not stop the electrical activity being abnormal. This was beautifully shown by the Irish with 51 infants with encephalopathy and risk for HIE they studied. 12 of these babies had seizures. Overall, only 9% of the time were the seizures actually clinically recognised. And even when you might think the Irish weren't that good at recognising them, you put the video out and really looked at it against the video, and the EEG, only 20% of the time could you actually see anything at all correlating. 3 infants were aggressively treated with up to 3 drugs for 31 clinical events and no seizures were seen. And 2 infants didn't receive any therapy. 1 had 38 seizures and the other had 56 seizures. So in other words, about half the babies got the wrong treatment. They either got treated when they shouldn't have been, or they didn't get treated when they should have been. We all know that when we come to put the EEG leads on babies, we're not using the same number of leads as we do in an adult. We're using what we call reduced montage. It only has 8 electrodes that usually go around this. This is often summarized even to 1 central lead in here. And of course, for the AEG, it may be a single across the central or 2, 1 per hemisphere, left and right, that are placed. Now, AEG seizure patterns, we'll get on and talk more about the Australian trial at the end, but this is, as many of you know, what we would be looking for on the compressed trace. this rise in the AEEG background. And in fact, I was first introduced to this technology by Chris Williams and Alistair when they were using it in the fetal lamb up in Auckland. And I took a machine down with me to Christchurch and started using it on our babies down there. But you can see here this very monotonous lower margin, upper margin, and then the shift where the lower margin moves up and the upper margin moves up, and you've got this very stereotypic like seizure, and you can see the seizure coming through here and through here. And obviously this is another seizure event occurring here. Sometimes it's more difficult, especially if the seizures have got a very slow, low frequency, to be able to see where it is. And that's when the seizure algorithm was developed for the monitor that's commonly used across Australia and New Zealand. That little yellow line that this line is on, and the yellow line showing up here, is showing you this rhythmic abnormal discharge. So how good is AEG for seizure detection? It depends on who has studied it and what ways they've studied it. Many have just taken traditional EEGs and compressed that down and said, well, if I was just looking at a single channel, would I have picked these up through a compressed technology? And that's where it's come out as low as 25 or 40%. However, others have said, well, we might not pick up every seizures, but at least we'll pick up if the baby is having seizures. So overall, you would pick up more like 80% of any baby that's definitely having a seizure. Most of the seizures are occurring in the central leads, not in other leads. And so hence, you're more likely to pick those up. And certainly, you know, if you look at the raw EEG alongside the AEG, then every statistic that you can look at goes up considerably in terms of the sensitivity and specificity. Now, when you come to thinking about seizures, though, I don't want you just to think you need EEG to diagnose this. Of course, there are very important aspects of the neurological evaluation: family history, prenatal course, perinatal history, your general exam, and the neurological exam all contribute considerably. And this is a very nice summary article of the approach to neonatal seizures. In addition, of course, you want to be able to make sure you're not missing something very simple and treatable, such as abnormal glucose or electrolytes, particularly calcium or vitamin D deficiency. You want to be looking at the full blood count as well, and then thinking about getting this EEG. Secondary to that, of course, you do want to make sure you've got no acidemia or have not missed HIE. Evaluate for infection, consider an LP, and now we'll talk a little more later about rapid genetic screening. Then neuroimaging is going to come in, and obviously during all of this time point, you hopefully are monitoring and treating appropriately. Treatment algorithms should exist in your NICU to standardise care, because time from seizure recognition or seizure concern till the time your first drug is delivered is a very important quality metric. There are a number of algorithms now that have been brought in, and this is one that's, again, nice to assess electrolytes and glucose, get your EEG on, confirm if your seizures are real, and start treatment immediately. And then, you know, being able to get them to a centre that can monitor if you don't have one, potentially using a short-acting agent so that you don't hide the capacity for somebody to actually be able to truly know whether seizures were happening or not by preventing that big load of phenobarbital can be helpful. If seizures are confirmed, then phenobarbital is your first line, and we'll talk about that more. This was a very important second way of doing this. Again, checking glucose electrolytes, phenobarbital, levetiracetam, phenytoin, and midazolam. This was really led to being reinforced that phenobarbital was the primary agent to be used after the important trial that was really undertaken to show that levetiracetam was as good or better than phenobarbital because of the concerns everyone has about phenobarbital as a drug. Having said that, what they did, and what was a very important observation, was they took a lot of infants that were at risk of having seizures. So any baby with HIE or at risk or any clinical suspicion, they got EEG on immediately. They had central readers looking immediately for any seizures. And as soon as seizures were detected, they were randomized to either phenobarbital or levetiracetam. If the seizures then persisted, they either got further doses, and then if they persisted further, they got switched between the two drugs. And here were their timelines. So you had this long to respond. What did they find? Well, contrary to what they had hoped for, what they found was that overwhelmingly, the primary outcome measure, which was seizure cessation at 24 hours after the onset, was overwhelmingly better in phenobarbital than in levetiracetam. And indeed, the secondary outcomes, particularly 1 hour seizure cessation with phenobarbital, was 93% versus around 50% with levetiracetam. So without a doubt, in this study, if you got EEG on early, you had a response immediately to the onset of seizures. There was an incredibly high success rate with a single dose or single dose plus one additional dose of phenobarbital. This led to the International League Against Epilepsy, which I had the privilege of being part of, leading to the recommendations that phenobarbital should be first line. And if infants didn't respond, then phenytoin or levetiracetam could be used as second line. Following cessation of the acute provoked seizures without any evidence for a neonatal onset epilepsy that we'll talk about in a moment, these medications should not be charted with any maintenance. Particularly during hypothermia, the half-life of phenobarbital was around 300 hours. Once you have loaded, you will cover the entire period, as Alistair showed us, for the vulnerability of seizures. You do not need maintenance dosing. And in fact, the recommendation from this society and from the American Academy of Neurology is that all anti-seizure medications are discontinued before discharge, regardless of the extent of injury on MRI or the EEG findings during the admission. So treatment algorithms are needed in your NICU to standardized care, and time from seizure recognition is important. As I've said, most infants do not need maintenance anti-seizure drugs, and there's an enormous amount of literature around this now. This was some of the work that showed the unadjusted epilepsy-free, because why were we keeping, when I started, we used to keep them on for 2 years. When you started phenobarbital as a baby, you automatically got 2 years of treatment. And why we did that was because we believed if we prevented the seizures, we would prevent the onset of epilepsy. And what has been shown here is that survival without epilepsy, whether you were maintained on anti-seizure medications or discontinued, in fact, those who were discontinued had a survival without epilepsy, which was higher than those who were continued. What we don't know is how do we address the issue that was attempted to be addressed in Australia, which is how do we translate into broader NICUs when you've got a lot of community-based NICUs and a lot of smaller NICUs that are trying to treat seizures or understand how to manage seizures with technologies like AEEG. Does monitoring and effective targeted anti-seizure treatment really improve outcomes? And that's what we would have thought from everything I've shown you. Fewer seizures, more effective targeted treatment driven by better technology would improve outcomes. So that led Rod and others in Australia to undertake this important trial where they randomized 212 babies to either monitoring with AEEG and that driving where the treatment was given, compared to just watching the baby and clinically deciding whether the baby needed treatment. What they found, unlike the thought that we would have, that monitoring them and treating them for electroencephalographic events would reduce seizure burden. In fact, the seizure burden in those babies was higher than those in the clinical seizure group. So monitoring them and targeting the treatment did not lead to a reduced seizure burden. In fact, the per day burdens you can see here, and from 12 to 72 hours from birth, in fact, it was almost double. although there wasn't any difference in the amount of phenobarbital or medications they got. So they had more seizures, but they didn't get more medication. That also seems a little bit unusual. Now, why, when this trial came out and did not show any improvement with monitoring, it had the rest of the seizure community and a little bit, including myself, and a little bit of a dilemma about what was this about and why would monitoring not reduce seizure burden and improve outcomes. And it was felt that this may have been driven by the fact the AEG was started pretty late. As Alistair's work and clinical work has shown, seizures are starting at around 12 to 14 hours after birth. And if you're starting your monitoring 24 hours later and there hasn't been treatment given because no one's been sure whether there were seizures, then you've missed maybe up to 12 hours of seizure burden. So you may have missed the bulk of the seizure burden. And we know if you start the drugs late, it's much, much harder because of this kindling to break the seizures. It's also important to understand that AEG can't always provide completely accurate definition of the seizure burden, which was what they were then determining the seizure burden on, and because of the compressed trace that was really focused on the longer seizures, and that maybe a lot of the seizure burden had gone undetected if there were a lot of brief seizures. So it was really challenging to understand how to take this into clinical practice. It obviously wasn't reassuring for the investigators in Australia that monitoring was even worth it. I think there was a lot that I learned about the fact that you can't just put these technologies into units without a lot of education and training for every member of the bedside team to know what to do with this and how to respond to it. And in fact, unfortunately, Rod never did an analysis looking at how many times the monitor went off and what or when people responded to it, a little bit similar to the cerebral oximetry monitoring study. What about genetic testing? I'm not sure what is happening in Australasia and around Asia, but I'd be interested to know, when do we do genetic testing? Well, one of the big areas that we have really discovered a lot with genetic testing has been the so-called benign familial neonatal epilepsy groups. And when I was growing up, these used to be called fifth-day fits. These were babies who looked otherwise pretty well, but they just suddenly started having seizures sometime between day 2 and 6, typically around day 4 to 5. They were otherwise neurologically apparently normal-looking babies. They had no abnormalities on imaging. They were typically clonic-type seizures. And now we have discovered that a huge number of these infants have genetic potassium channel defects in the KCNQ area, both KCNQ2 and 3, and we'll talk more about that disorder in a minute. That is a little bit different from another related, which is the self-limited familial neonatal infantile. So just add the infantile epilepsy. And these children tend to present a little bit later. They can present anywhere up to 2 years of age and have to be distinguished sometimes from febrile seizures. And these children have a defect that's more commonly found in the SCN2A defect. Now, KCNQ2 has really become one of the quintessential genetic epilepsy syndrome because it really shed a lot of light on the fact that these disorders really accounted for quite a number of these self-limited familial neonatal epilepsies. But a word of caution, because they don't only contribute, some of these gene defects can be quite significant and profound and produce a very significant epileptic encephalopathy that can look and can progress into a very, very severe form. They really, as I've said, encode these heteromas around a voltage-gated potassium channel that regulates neuronal excitability. And the risk of future epilepsy, we used to say that these fifth-day fits were benign and the kids would be fine and they'd never ever have problems again. But when you look at this group now, genetically, about a quarter of them will go on to have some form of epilepsy later in life. The management, most importantly, for the children that have this specific genetic defect is different than any other form of seizure management and has to be treated with sodium channel blockers, particularly carbamazepine. Now, when it's very self-limited and they only seize for 12 or 24 hours, which a small group of them will, they probably don't need much treatment at all. But phenobarbital won't do much for these children. They really need carbamazepine to be able to modulate. So it is altering and deciding therapeutic intervention. The other group of genetic epileptic encephalopathies that's really important to understand are the rarer but devastating group of early infantile developmental and epileptic encephalopathies, so-called EIDEEs, which when I was growing up used to be known as epileptic myoclonic encephalopathies or early infantile epileptic encephalopathies or Ohtahara syndrome. Again, now we distinguish these very much in terms of their gene defect that is underlying them, and therefore what the likely inheritance is for family genetic counselling, and also what the likely outcome is for the child, with many of them requiring multiple anti-epileptic drugs and having progressive nature, both in terms of the neurological impact. It is plausible as we move towards the gene N=1 therapy era, which we are now entering in the US, that some of these conditions are going to be hot off the press as genetic modifiable diseases. And as long as we can diagnose them early, before there is neurological impact, then we can potentially salvage any long-term deficit. How common are these disorders when you start to look at it? And this was a nice study that looked at genetic testing results for newborns with neonatal epilepsy syndromes that were a little bit outside the general HIE. So now we're in the 30 to 40% of kids that didn't fit the HIE. Although now there is a group of studies that have been done even in therapeutic hypothermia showing that there is an overlap of at least 20% of the children undergoing therapeutic hypothermia who may fall into some of these genetic underpinnings as well. So if you look at those that present with more of an epileptic encephalopathy, the yield will be very high. Benign neonatal epilepsies in this, but the familial epilepsies, again, very high. And brain malformation syndromes also obviously very high. So what does that mean in terms of this talk and what I would like you to take away and think? I want you to be aware that there are a lot of infants that are at risk for seizures because of this vulnerability that occurs around this unique developmental period in the brain where you have a preponderance of excitatory amino acids and receptors with a deficit of inhibition. And this not only relates to term infants with HIE and neonatal encephalopathy, but also to infants undergoing perfusional defects and things like cardiac disease, who have infectious diseases, who, as I said, it takes nothing more than a strong nor'wester to be able to produce this. And obviously any infant that's having abnormal movements. We really do need to have a low threshold for confirming the seizures as quickly as possible, either with a full EEG or AEG, and really getting good training in how to interpret that. And the treatment has to be as early as possible to be effective. If you remember the original Painter trials, that was one of the only other randomized controlled trial, and Mike Painter's trial, phenobarbital was effective less than 50% of the time, but it was started late. And this may have been the same issue in the NEST trial. So we really want to be able to start early, as we saw in the levetiracetam comparison, where there was 90% plus efficacy. Second-line phenotone or levetiracetam, and if status is present, upregulate quickly to IV midazolam infusions. Think about establishing the etiology and consider sodium channel blockade if you are suspicious that this could be a KCNQ2 defect. And please consider not charting maintenance and stopping anti-epileptic drugs as soon as possible. As soon as your seizures are controlled, you don't need to chart any more drug. And I hope that has given some opportunity to consider some common topics, and I hope that there'll be some questions related to that. And I really appreciate the privilege of being able to share both in my emotional but real reflection on Alistair and the work that he contributed to that is here, but also to our care of newborns with seizures. Thank you so much, and I look forward to questions.
Thank you, Terrie. That was a great overview. It started, of course, with a beautiful tribute to Alistair, and Eleanor is thanking you in the chat box for all your thoughts and love for him, and what we can see and find here, how he has it knowledge, but also his knowledge transfer to you and to many, many others has been sort of remarkable and very educational for all of us to get better. You gave a great overview about seizures, the risks, the causes, and you went to the triangle, I call them, biochemical changes, pathological changes, and electrical changes. And I don't know, I still find it hard in my heart to get those three together. You brought us the items about the difficulties in the clinical diagnosis of seizures, and even the difficulties of AEG and EEG diagnosis of seizures. Then you brought us to the statements, and I highly recommend, I put it in the chat box, that consensus guideline for 2023. It's very dry, but I think it has really good sort of clinical helpful points to describe. You brought us to the ROD study with the clinical versus AEG comparisons, which had always question marks around it. And then you brought us what I think is for a lot of us maybe not standard practice, but it was really helpful to think about it, additional tests. And particularly in babies who might not fit, like why is this baby, is this HIE, what is this? To then sort of add that to it with your clinical recommendations at the end. Let's go to some questions. I think the first question was from Gayatri already about, should we stop medications at discharge for infants with an abnormal MRI?
Yeah, so this was actually a very difficult one even for me to, see an infant with a significant cortical infarct in particular, and particularly those infants with hemorrhagic transformation in their cortical infarct, and know that it had taken me a bit to get their seizures under control, to say, well, I'm not going to continue on anti-epileptic medication. But actually what I've found is that if you treat them, as was shown by Alice, if you treat them acutely during the time of the acute insult, and you get the seizures under control, and then you don't chart maintenance, but you continue to monitor the infant closely, that those who are going to need to continue will start to emerge with recurrence of seizures. And if those seizures recur, which is actually pretty rare, like we're just finishing collecting data on about 500 infants, and it really is less than 5 to 10% of them, then we've restarted levetiracetam for a period of 6 to 12 weeks as an outpatient. So then they'll go home on levetiracetam, whereas they would have been on mainly phenobarbital in the neonatal unit, but we'll start them on oral levetiracetam to go home as an outpatient on that for 6 to 12 weeks. So it actually works as a really nice transition point too between medications. And it is much rarer. There are quite a number of these babies, particularly, my colleagues who'd had big strokes and felt very strongly about those as well. They've been quite impressed by how many of these babies they would have thought would have been at risk and who haven't actually gone on to have seizures at any time. Now, that doesn't mean they won't at a later time point in their life. And of course, the family have to be educated and made aware about what to look for. And in particular, even though it's scary to talk about, I believe it's our responsibility to talk about infantile spasms in the babies who've got significant MRI injury, because those babies are at high risk. And if their parents don't know what to look for at home, then they will often turn up late. And that makes, again, treatment of the spasms very challenging. So it's very important that the parents know what to look for, and to give the parents, like if you're concerned and you're really not sure and you're worried, pick up the phone and call an ambulance. Just bring the child to the emergency room. But the advantages of that are you're really targeting the treatment to the babies who need it, rather than putting, as it was when I grew up, large numbers of babies on a long number of months, years of phenobarbital for no gain and probable detriment. I did see a question about phenobarbital, in terms of its apoptotic effect as a drug. And this is a very important point, that when phenobarbital is given to a healthy brain, just like anesthetic agents actually, you produce neuronal apoptosis. That is absolutely true. Now, the apoptosis is principally seen in the hippocampus, which is actually an area that can regenerate neurons. We only have a few of those regions in our brain, but the hippocampus and the olfactory bulb are those kinds of regions. But it's not something we want to inspire, just like we don't want prolonged use of anesthesia for protracted periods in our babies either. Having said that, in the setting of HIE or an ischemic insult, that's not what we see. We see neuroprotective effects from phenobarbital. We do not see accelerated apoptosis. So it's a very different setting. So yes, we want to avoid phenobarbital exposure in healthy brains, and we want to neuroprotect infants with HIE who've had risk of ischemic injury to those same neurons.
A bit of follow-up on these treatments. There's a question about what if I don't have phenobarb? What should I then use as first line? And then there's a question about the second line. Well, phenytoin is in the Australian guidelines, but is it really effective? When should we use that? And then there's questions, of course, about the third line with medications. One of them I've never heard of. But so what do you think? Where do we go?
Yeah. So that's why we tried to, in the ILAE, tried to, get all of the data that we could together from all of the published works that we could. And it's pretty clear that phenobarbital really, particularly after this levetiracetam trial of NeoLev, is outstandingly better. It's unusual that you don't have phenobarbital. It's one of the oldest, cheapest, dirtiest kind of drugs that exists, which is why everybody wants to get rid of it. And so it is unusual. There's very few drugs that have exactly its breadth of anti-epileptic effect. The benzodiazepines are probably the closest. So if you didn't have something right up front, then probably anything in the benzodiazepine range is going to give you the closest hitting effect. In second-line agents, the published data comes out even on levetiracetam and phenytoin. My personal preference is levetiracetam. I also, similar to Nick, I've not always been impressed by phenytoin. I give it and I feel like I've just given water because I just about never get bang for my buck. I get more bang for my buck from additional phenobarb. I will pretty quickly go to 40 on bad babies. And again, you are going to be judging the level of surveillance and the level of aggressiveness based on the extent of injury and the likelihood these seizures are going to be difficult to capture in the baby. So if you've given 20 per kilo of phenobarb and it's a bad baby and the seizures emerge aggressively and early after that first dose, hit them again with 20. Just hit them again. More often than not, those babies are receiving respiratory support anyway. And so just get their level up and have the best chance of capturing them. If that doesn't capture them, then I pretty quickly go to loading them with levetiracetam and try and maximize that. And then if that doesn't capture them, then most of my ones, sometimes my neurology colleagues will always want phenytoin added, but I'm pretty quickly getting the midazolam infusion up and running and dialing that up. The worst kids by far actually for seizures are the kids who have subpial temporal lobe hemorrhages. And these are sometimes children who will be on the postnatal ward just kind of hanging out. No one may have recognized anything around birth, and they will start to have seizures sometime around 12, 24 hours, and they can get seizing fast because these subpial hemorrhages really wrap around the whole temporal lobe and the hippocampus, and they're right in the most seizurogenic area of the brain, and the presence of the hemorrhage just quickly ramps up, and they fly off quickly. So they often are the ones that I'm literally standing by the EEG, dosing them, trying to capture them. And you'll see it on the ultrasound. You'll see a little bit of hemorrhage on the ultrasound in that temporal lobe area. About 70% of subpials are occurring in the temporal lobe area. And again, there may be kids who've had a traumatic delivery, but they may not have had any particular inciting event. I see there's a question about levetiracetam dosing too for maintenance. I always use higher dosing IV for capturing the kids initially. But when the kids go home, I am actually using, in the middle of those two doses, I'm using 45, usually 15 per kilo TID when they first go home, but they pretty quickly grow and I don't adjust the dose. So they just stay on that dose even as they grow. And then we just wean it out over 1 week. Levetiracetam can be weaned out pretty quickly without any concern. So that's been the dose we've tended to use, unless you're dealing with a very complex child where seizures were difficult to capture. They recur very quickly. Certainly, if you've got any of these other genetic and epileptic encephalopathies, then that's a whole different paradigm. Is whole genome sequencing becoming available routinely in some of your NICUs?
It would be, no, I think if you ask for it, it's available. But certainly in my setting, but there might be other settings where that hasn't been sort of practice. But I do feel there's quite a proportion of babies where you go like, you know what, it doesn't really fit with an insult or an infarct. And you generally know that sort of after the MRI, you go like, oh, what was this? And why was this? And I think it's a really good idea, not only for knowledge, and maybe it's much more common than you think. And it's probably time we start testing for that more regularly in cases, which at least all the ones we don't know for sure why they reached that point that they needed therapeutic hypothermia. That would be my suggestion, but I'm happy to hear other suggestions on top of that.
And I think certainly any of the children who have unexplained epilepsy syndromes at all, like particularly if your neuroimaging is negative, or you've got a baby that presents at 2 or 3 days and those kids just should automatically activate. We're fortunate here we've got now rapid, so we can get a result back in 72 hours on an ultra rapid. And those machines are becoming, the cost just keeps falling like the sky in terms of availability and accessibility, particularly for the common genetic conditions. But those are neonatal neuromuscular diseases are by far the highest hit rate for the genetic screening at the moment out of the neonatal intensive care unit. But I think we're moving towards an era where we're going to start to see a lot more, availability and requirement for us to have a low threshold for rapid whole genome because it might influence treatment decisions, particularly as we get towards some of these genetic therapies that could really save lives.
So there's a couple of questions you mentioned in your talk as well if it's gone, stop it. Can you highlight how would you do that? Stopping of all the medications. You got a baby, you got seizures, you do 1 or 2 medications, and then how do you stop? When do you stop? How quickly do you stop?
I think the babies kind of bifurcate in my experience. Obviously, hypothermia, as Alistair showed too, is able to suppress seizures. I mean, you'll have about a 50% reduction in your seizure burden just by the administration of hypothermia. And in fact, there are 3 infants in my history that including one of these subpeel temporal lobe babies actually, who I had on 4 medications at max doses that I couldn't capture their seizures. And I called them. I called all 3 of them and they all stopped when they got called. So cooling is also it is a known anti-seizure treatment, actually. So that's why we always worry about rewarming in these kids at the time, particularly if we've had their seizures under control. So the kids to me bifurcate. There's a group of them that just need a single dose of phenobarbital, 20 per kilo. They were building up, you got them, you stopped them, and then you don't see anything else emerge. And as long as you got them early and your dose was adequate, and they've not had a big hit, and you're not had a profound secondary energy failure, then they'll settle down and they don't need any more at all. They just needed that one hit at the time they were maximally angry. And then there's this other group, and the other group are the group you're talking about. And I think that group is the group that are recognized late. So that group have, the horse is out of the barn, it's running around the field, it's crazy. You're trying to capture the crazy horse. And now you've got to give a lot of drugs to get that horse under control. So you've given 20, 10, phenytoin, didn't work, levetiracetam, didn't work, my midaz infusion's up. I finally seem to have got things under control now after about 12 hours of all, and I've got all these drugs on board. Again, what we do is we don't chart maintenance of anything. So we just use the doses that we've charted, and then we look at what we're going to continue or discontinue. So if the phenytoin didn't give us anything, if it never stopped anything, we've given the one dose, the loading dose, we never give any more. If the levetiracetam didn't give us anything, but we know we're going to have to continue it probably as an outpatient for 6 weeks in this bad baby that took us a lot to get under control, we'll leave that in and we'll start maintenance for that. The phenobarb we often don't chart maintenance for. We just have given those big doses at the start, but we'll leave the levetiracetam in and then we'll slowly start weaning the midaz down and see how they go. Now, if the levetiracetam is dosed at the right amount and we're weaning the midaz down and they break through, then we might give another 10 per kilo of phenobarb and just give them a bit more time to kind of calm down. But that's typically how we'll tend to sort of doctor it. And more often than not, as I say, the phenytoin doesn't give me anything, so they don't get any more doses. Occasionally, we've had one baby that did seem to respond to it, but it's pretty rare. So then you've got this natural aggression, but we don't chart maintenance. So that's the key to you. Load them to capture them, but then be very thoughtful about what's going to be maintained.
You made one comment which I really appreciated. Whenever we get a baby, particularly when it's suspect of HIE, with abnormal neurology, they send it for us for therapeutic hypothermia, and in that time, somebody observes abnormal neonatal movement. Whether or not that is seizures or not, logically, it's more 12 hours than it is 2 hours, and indeed they give phenobarb at that time. And you said, if you can, wait and get the diagnosis first, and in the meantime give a little midazolam. How often have you tried that? That sounds awesome to me.
Yeah, midaz or lorazepam would be the two that we would give as short acting. We do it pretty often in transport if they're really concerned. As I've said, a lot of the abnormal movements that these kids do are a symptom of their encephalopathy, particularly if they've taken a deep nuclear grey matter hit. They will have a lot of posturing, those kids, and a lot of that posturing isn't true seizures, cortical seizures that are going to respond to the types of drugs we give. They're more, a sign of the dysfunction of that deep grey matter.
Thanks. Time for some last questions. One about oral phenobarb and two about pyridoxine as a sort of an additive if you run out of everything. Your comments.
Yeah, so there was another question earlier about how fast you can give phenobarb. I hesitate to tell you how fast I've given it. Sometimes I've given it, if the kid is intubated, there's no reason, Nick may argue with me about this. I've not had a lot of cardiovascular instability outside of what the kid may be having anyway, associated with a 20 per kilo load of phenobarb. If I'm up at 80, or if I'm anesthetizing the baby with phenobarbital, absolutely, I might start to see that, but it hasn't been my experience.
Yeah. All right. Is it the same thing? Yeah. Oh, same.
Right. Got it.
You can give the phenobarbital faster than 30 minutes. It's just the pumps often don't work faster than 30 minutes, so the nurses are used to putting it on pump over 30 minutes and being worried about apnea associated with it. So depending on what your airway situation is and what control you've got of it, because by far apnea is the commonest side effect you might see. How many doses of phenobarb can you give? Certainly you can give 20 and 20. The max benefit, I think, hits at 60. Once you're above 60, you're going to get very little gain for your dollar. And I have pushed at times higher than that, but really, you can give 20 and 20 and then another 10 and then another 10, and then I wouldn't give more than that. You will be very sedated and need respiratory support up at those kinds of doses. There is a good question about pyridoxine and pyridoxal phosphate, flinic acid and biotin, when to give those and when to consider them. And obviously in any of the infants where you are dealing with a slightly atypical presentation that doesn't look like classic HIE, then they should be at least in your 3rd to 4th line management option. And again, you can be, obviously establishing many of these diagnoses now by genetics pretty quickly. but you can be also rolling out the drugs and giving them a trial on EEG. Those drugs have to be given on trial with EEG running. You can't just pull them out just to say, you know, I'm just going to throw everything at you. I also haven't discussed some of the newer agents that are now available that I think are giving us. Lacosamide in particular is having a great range of efficacy for us in some of the children with atypical neonatal onset epilepsies, and we've found it to be extraordinarily helpful in those children. I personally have used now the cannabinoids a number of times, and the kids who are on 6, 7, 8 anti-epileptic drugs with these atypical early infantile, very devastating developmental epileptic encephalopathies. So there are a number of other drugs, but I think for many of you, you would only be using those in the setting of input from expert pediatric epilepsy teams that would be helping you. And you really are in a very small group of these babies, but recognizing them and recognizing them early and distinguishing them is important because you know, they will present with more of these later onset, myoclonic, more predominant types of seizures, and that's important to understand the difference.
Right. Look, it's 2 o'clock. Thank you so much, Terrie, for this wonderful tribute and overview for today. Thank you all for attending. We will be back next week where we're going to update or tell you about the updates in the new ILCOR resuscitation guidelines. Thank you, Terrie. Thank you, everybody, for attending.